time. Let's see, sorry. Okay, so we'll get started here. So I have nothing to disclose. So just some objectives today about urinary diversion. We'll talk a little bit about the historical perspectives, some anatomic and functional considerations and techniques, metabolic consequences, types of urinary diversion, techniques, complications, and outcomes, as well as long-term complications and follow-up. So we'll start with Slido. If you guys all have a smartphone, you can use your camera to do the QR code here. And just the first question, just to see where everyone's tuning in from. So you can join here and just free type response. It's my first time using Slido, so. Cool, Philly. I'll give everyone a couple of minutes to respond. I just have a couple of baseline questions, and then we'll kind of get into the meat of the presentation. All right. Looks like New Orleans is winning. Oh, and also I'll answer all the questions at the end. So just use the Q&A button and I'll get to all the questions toward the end of the presentation. So just save them up there and then I'll address as many as I can get through with the time limitation. All right, let's go to the next question here. So this is just what PGY year are you? Those members of the audience, just kind of see who's tuning in. All right. Lots of PGY 3s, it looks like. All right. All right, good. All right, and then the other question is just out of sheer curiosity. What is your institution doing in terms of pre-op COVID testing? I thought I'd poll the audience while I had a big group. All right. All right, antibody test and double testing. All right. Okay, and then one last introductory question. Just in terms of urinary diversions performed at your institution, how are they majority performed there? Can you guys, is it working? I don't see any responses yet, sorry. Is it not working? Oh, there we go. Someone responded. All right. Majority open, it looks like. Okay. So I'll just move on here. So we'll go back to the PowerPoint. So let's start with a little historical perspective in terms of urinary diversions. Obviously urinary diversions are not new. These have been performed since the 1850s. Sir John Simon in London performed really what was the first urinary diversion, doing a ureteral proctostomy. And this is a picture of how he performed it, basically tying the ureter to the rectum and creating and puncturing through the rectum to create a fistula between the ureters and the rectum, and relying on the external anal sphincter to be the continence mechanism. And then Thomas Smith in London was the first to do a actual ureterointestinal anastomosis in 1879, and there's been many modifications that we'll kind of go over. Down here is a picture of all the different types of ureterointestinal anastomoses, and we'll go over some of these. As I said, majority of the first urinary diversions were all rectal or rectosigmoid pouches in a variety of constructs and reliant on the anal sphincter for continence. However, the risks of doing this are metabolic disturbances and malignancy. So, and what led to the creation of external stomas was really the development of a useful stoma device that wasn't cumbersome. This is one of the original stoma devices that was performed. It was very cumbersome and hard and very difficult for patients to use. And so it wasn't really until the creation of a urostomy device that you could really manage urine from a stoma. So in 1934, Henry Koenig invented this appliance, which you can see the patent for here, using thin rubber sheets and an adapter to prevent escape of fluid. And then Herman Rutzen was the one who actually manufactured these. So this eased the ability to manage abdominal stomas with urine. Eugene Bricker was a general surgeon in St. Louis who popularized and first described the ileal conduit. And described these in patients undergoing pelvic exoneration for a variety of pelvic malignancies. And it wasn't until really the Rutzen bag that they could manage these incontinent stomas easily. So now let's go back to today. So a urinary diversion, as you all know, is a surgical rerouting of urine to exit the body other than the native bladder and or the urethra. These can be incontinent or continent, and we'll kind of go through each of these. So there's a variety of indications for urinary diversion, oncologic with bladder cancer, genital urinary malignancies, occasionally other pelvic malignancies like colon cancer, rectal cancer, gynecologic malignancies. Also patients with neurogenic bladder or end-stage bladders as a result of neurogenic causes, radiation cystitis, idiopathic end-stage bladders or interstitial cystitis, chronic pelvic pain, congenital anomalies. You may consider doing urinary diversions in patients with hostile bladders prior to renal transplant, and also in cases of a devastated outlet that are completely obstructed, or patients who are fluidly incontinent with or without fistulae, and you would consider urinary diversion in these patients. So first, let's talk a little bit about surgical anatomy. So let's start at the stomach. While this is rarely used today, this is testable and may show up on your written boards or your in-service exams. So the stomach can be used as an incontinent or a continent diversion, and can also be used as a cystoplasty for bladder augmentation. The arterial anatomy comes from the celiac artery, which branches into the left gastric, splenic, and hepatic arteries. Occasionally, the left gastroepiploic will be atretic, and the right gastroepiploic tends to be more reliable. When this is used, they utilize the antrum or a wedge of the gastric body, and this is based typically on the right gastroepiploic artery. And this is actually a really long pedicle that can reach all the way down into the pelvis. If the stomach is used and you use the antrum completely, then a Billroth 1 reconstruction, where the stomach to duodenum anastomosis is performed. Typically, keep the omentum attached to the stomach, but has to be disconnected from the colon when using the stomach in this setting. Small bowel is the most common. The small bowel in total length is somewhere between 50 and 30 feet, depending on the patient. As you know, divided into 3 sections. The duodenum is the largest in diameter and is essentially never used in urinary diversions. The jejunum makes up 40% of the small bowel, supplied by the superior mesenteric artery and veins. And the arterial arcades are typically single, and they're much larger vessels and tend to have a thinner mesentery compared to the ileum, and very rarely used, and we'll go over some of the reasons why. The ileum represents a majority of the small bowel, around 60%. Again, same blood supply. And this is the most distal part of the small bowel. It has multiple arterial arcades and small vessels relative to the jejunum. It tends to have a thicker mesentery. At the terminal ileum, you can see in this picture is this ileocecal fold, or the ligament of Treves. This is Sir Frederick Treves, who was a surgeon in London. He was actually, he helped take care of the Elephant Man. And he popularized appendiceal surgery and described this ileocecal fold, and is really the only area of the small bowel that has anti-mesenteric fat. So if you're confused in a belly with lots of adhesions, if they still have an appendix, or still have the ileocecal valve, you should find this ileocecal fold here to help you identify your anatomy. So the small bowel, experimentally, up to 15 centimeters of jejunum or ileum can survive just lateral to a single straight vessel off of an arcade, but you obviously don't want to assume this. Clinically, up to 8 centimeters may survive on a single straight vessel. And this will become important when you're doing Turnbull or loop type stomas, and I'll show you some of that in a little bit. Importantly, there's 2 parts of the small bowel that may lie within the pelvis, which has implications in patients who have whole pelvic radiation. The last 2 inches of the terminal ileum may be exposed to pelvic radiation, as well as about 5 feet away from the ligament of Treitz has a long mesentery and may also be exposed as well to pelvic radiation. So the colon anatomy, as everyone very well knows from medical school, the cecum in the right colon is supplied by the SMA via the ileocolic artery and the right colic and the middle colic. The middle colic may have a variable course and branching. Typically occurs closer to the hepatic flexure than really in the middle of the transverse colon. The ileocecal junction is fixed in the right lower quadrant by 2 peritoneal bands. The transverse colon is supplied by the middle colic artery, as well as collateral supply from the marginal artery of Drummond, which is here. You can see my pointer. And then the left colon our descending colon is supplied from the inferior mesenteric artery via the left colic in sigmoid and hemorrhoidal or superior rectal branches. The middle rectal comes from the internal iliac. So importantly, there's 2 watershed points that may be important clinically when doing urinary diversion work. Griffith's point is in the splenic flexure at the junction between the middle colic and the left colic. And then also Sudak's point, which is at the junction between the superior rectal artery and the sigmoid artery, which are with hypotension or extreme blood loss, may create ischemia in these areas. So in terms of urinary diversion, how do you decide which diversion is right for the patient? There's lots of things you have to consider. You have to consider the patient's anatomy, what prior surgeries the patient has had, what is the surgeon who's performing the surgery, what is their preference, what's their experience and training, what are the patient's preferences, social circumstances, what's their expectations and impact on their quality of life, what's the patient's risk tolerance. for complications, morbidity, and also, what is their ability to take care of a urinary diversion in terms of catheterization and irrigation. What are their medical comorbidities? Have they had prior bowel resections, prior radiation? Also, you want to evaluate their body habitus, surgical scars. Are they up to date on their colonoscopies? And also consider overall performance status, their frailty, what's their manual dexterity, as well as oncologic factors, which we'll go into, which may play a role in decision making for urinary diversion. So for the stomach, you may consider using a gastric segment in patients who have chronic kidney disease, who may be unable to tolerate metabolic acidosis that we see with ileal and colon urinary diversions. Patients who have multiple bowel resections and you're concerned about short gut, you may use the stomach to avoid some of these complications. Often the stomach is, sequestered and is less involved with adhesions from prior surgery and may be more accessible and easy. Also typically produces less mucus, less bacteriuria relative to ileum and colon, but can be associated with dumping syndrome, steatorrhea, and bilious vomiting. Jejunum, like I said, is essentially never used, and we'll go over some of the reasons why. And then ileum and colon, the ileum is very mobile, small in diameter, has good blood supply. However, the mobility may be impaired with excessive fat and short mesentery. And similarly, the colon is also mobile, larger diameter, and is less likely to be exposed in radiated fields, outside of the pelvis. The colon, the left, transverse, and ascending colon. So the metabolic complications, these are highly testable. This will show up for sure on your in-service exams, as well as your written boards and potentially even your oral boards. So we'll kind of go through each of these. So with the stomach, tends to be less permeable to urinary solutes and has a net excretion of chloride and hydrogen ions, and results in a hypochloremic, hypokalemic alkalosis. It can be exacerbated and severe if there's dehydration, nasotemia, which results in an increased aldosterone and further impairs bicarbonate excretion. These patients may present with lethargy, seizures, respiratory failure, or arrhythmias. The treatment for this in stable patients is histamine blockers or proton pump inhibitors. If there's a life-threatening alkalosis, arginine hydrochloride infusion can help restore the acid-base balance. One of the complications we see with stomach is hematuria dysuria syndrome, can occur in up to 24%, and this is a result of the acid. This can, patients may have bladder spasms, pain, hematuria, and may excoriate their skin. And this can be treated as well with histamine blockers. Experimentally in dogs, when using the antrum, can actually lead to increased serum gastrin levels, which can result in intestinal ulcers elsewhere in the GI tract. So you can treat these similarly with histamine antagonists or proton pump inhibitors. The jejunum, like I said, practically speaking, is not used. A loss of a significant proportion of the jejunum results in malabsorption of nutrients, fat, calcium, folic acid. The electrolyte profile in these patients is a hyponatremic, hypochloremic, and hyperkalemic metabolic acidosis. And this can be worsened and more evident if you use the proximal jejunum in patients who are on TPN. In the jejunum, there's an increased secretion of sodium chloride and water, and the jejunum is able to reabsorb potassium and hydrogen ions. So in the dehydrated state and stimulation of the renin-angiotensin system, the kidneys reabsorb sodium and lose potassium, and this potassium is then reabsorbed by the jejunum, and the jejunum further loses that sodium, resulting in this electrolyte abnormality. These patients similarly will have lethargy, nausea, vomiting, severe dehydration, and weakness. The treatment is fluids and bicarb. Long-term, you can use salt tabs or thiazides have been used to manage the hyperkalemia, and if persistent, you may have to remove the jejunal segment if one was used, but I've never seen that. The ileum and the colon are the most common. Of course, you see a hyperchloremic, hypokalemic metabolic acidosis, and the incidence of this is around 25% in patients with urinary diversion. obviously more common in patients with continent diversions relative to incontinent diversions. Patients may be anorexic, they have weight loss, polydipsia, lethargy, and this profile is a result of ammonium chloride absorption. To treat these patients, you may use an alkalizing agent, sodium bicarb, potassium citrate, or it can block chloride transport, and can use chlorpromazine or nicotinic acid, which inhibit cyclic AMP and reduce the chloride transport to reduce help reduce the acidosis or treat the acidosis. You want to avoid nicotinic acid in patients with peptic ulcer disease as well as liver dysfunction. With ileum and colon, with colon more commonly, there's a total body loss of potassium. This is most common with ureteral SIGs. The ileum allows for some reabsorption of potassium, but colonic diversions cannot absorb potassium and therefore more likely to have a total body deficit. If the patient is acidotic and hypokalemic, you have to correct both. If you just correct the acidosis, it may potentiate hypokalemia. Also, urea and creatinine recognized can be reabsorbed by the bowel and may be a less reliable marker of renal function. In terms of other consequences, patients may have altered sensorium as a result of magnesium deficiency with renal magnesium wasting or nutritional depletions. Hyperammonemia you may see in patients with hepatic dysfunction or cirrhosis and can result in an ammoniogenic coma. The treatment for this is to drain the diversion with a catheter, reduce the contact time with the urine in the bowel. Can use oral neomycin, arginine glutamate for severe cases, or lactulose. Also recognize that the bowel can reabsorb phenytoin and methotrexate, so you may need to adjust these medications and adjust the dosing of these medications in patients with urinary diversions. Vitamin B12 malabsorption associated with loss of the ileum. This results in a megaloblastic anemia and neurologic abnormalities. This may take 3 to 5 years for it to present, as the B12 stores in the liver, may take a while to deplete them. So you can replace vitamin B12 with injection or with a nasal spray. Oftentimes people just treat them after about 5 years, regardless, and not necessarily check B12 levels. Additionally, bowel resection, especially the terminal ileum, may result in a malabsorption of bile salts. These bile salts can cause mucosal irritation and diarrhea, and also results in the lipids not being absorbed. Cholestyramine can be used to sequester these bile acids and help reduce the diarrhea in patients with chronic diarrhea after urinary diversions. And that can also be the bile acids because of the loss of the ileum as well as loss of the ileocecal valve. Those bile acids and the fatty acids in the colon result in this diarrhea. Also, with the loss of the ileocecal valve, there may be reflux of colonic bacteria into the ileum and have small intestinal overgrowth. May have deficiencies in fat-soluble vitamins, vitamin A, D, E, and K. Also, loss of the ileocecal valve changes the transit time. The ileocecal valve acts as a pause in the GI tract. It allows for absorption of nutrients. So with decreased, with a faster transit time, you may have impaired absorption of nutrients. You want to try to avoid resecting the ileocecal valve or using the ileocecal valve in your urinary diversion in patients with myelomeningocele, as this may exacerbate diarrhea and fast transit for patients with spina bifida. So now to move on toward the types of urinary diversions. So pre-op, counseling, it's important to discuss all the options with the patients in terms of all the variety of urinary diversions that are available. Discuss intraoperative scenarios that may alter your preoperative plan, like margin status if you're doing this with bladder cancer. A bowel prep with ERAS protocols is largely omitted when using small bowel. The different types of bowel preps can be mechanical, either a lavage, which is go lightly or new lightly, Miralax, and these are PEG electrolytes, and these are the safest in patients who have renal dysfunction underlying. You don't want to use cathartic types, which are magnesium citrate or sodium phosphate, which may result in more metabolic and electrolyte disturbances. Antibiotic bowel prep, typically we will use in patients with colon diversions. There's evidence that reduced surgical site infections and reduced C. diff infections. So we will use both mechanical and an antibiotic prep for colon urinary diversions. For ERAS protocols, there's a variety of protocols. Every center kind of has its own way of doing enhanced recovery. And this, remember, encompasses both preoperative factors, intraoperative management, as well as postoperative pathways. This has best been studied in radical cystectomy for bladder cancer, but it's been applied in other areas of urologic surgery. The goals of ERAS protocols, hasten recovery, have early return of bowel function, prevent malnutrition and deconditioning, reduce opioid use, and shorten length of stay in the hospital, and then potentially even improve quality of life of patients perioperatively. So, like I said, whichever diversion you're planning to use, you may need a backup plan. We'll kind of go over reasons. So before we move on to the urinary diversion types, just talk a little bit about principles of bowel work. It's important to have adequate bowel mobilization. You want exposure of the bowel serosa and clean off the mesentery when doing your bowel anastomosis. You want to ensure you're using a healthy segment of bowel. Maintain the blood supply, avoid tension, and ensure that your mesenteric incisions are not too deep and you're not shortening the mesentery and altering the blood supply. With robotic diversions, indocyanine green can be used to help show you what's healthy and what's not, or you can use a handheld Doppler if there's any concern. It's important to get hemostasis at the staple line. You can use pinpoint electrocautery there safely. During the bowel work, you want to prevent spillage of the enteric contents, so typically we'll towel off the abdomen to prevent spillage. You want serosas to serosa apposition. It's important not to strangulate, with your sutures, with your limbic sutures. You're just more, it's an apposition. And then you want to ensure that that the mesentery is aligned normally, and that you have proper alignment of the anti-mesenteric to anti-mesenteric sides of the bowel. And remember, water under the bridge, meaning that the diversion segment that you're using goes below, and that the anastomosis to bring the GI tract back in continuity typically is above. So there's different types of intestinal anastomosis, hand sewn or stapled, and they have similar outcomes with multiple randomized trials. Most commonly stapled. I can count, I think I've done a hand sewn anastomosis twice, in training. So, we don't get the same. So I don't have a ton of experience doing a hand sewn. Most commonly, and most people do a stapled anastomosis. For a side-to-side functional end-to-end anastomosis, which is most common. Typically we use a GIA 75 with a blue load times 2 or 3, and then a TA 60. Put sutures at the crotch here to prevent tension at the staple line, and then limber it over to the end, which is dealer's choice. Obviously the bowel work tends to be what results in majority of the complications with urinary diversion and with cystectomy. Intestinal leaks, are not common. May occur around day 12, but I've seen them as early as day 4 or 5. The risks for anastomotic leak of your intestinal anastomosis is ischemia, microvascular disease, infection, radiated bowel, technical errors, and staple misfires. Hemorrhage as a result of bowel work is rare. Ileus and bowel obstruction tend to be more common with ileum than with colon. You can also have stenosis or obstruction at your anastomosis as a result of edema or technical errors. You may have fistulas. Unrecognized bowel injuries typically present earlier if you missed a bowel injury that you left behind. Pseudo-obstruction or Ogilvie syndrome. However, these complications, may result in the risk of reoperation, and do have some risk of death, especially the intestinal anastomotic leaks. So in terms of the anastomosis for your ureteroenteric anastomoses, you want to minimize the mobilization of the ureter and use only what's needed for a tension-free anastomosis. Keep the adventitia intact. You want to use fine absorbable sutures in a watertight anastomosis, and you want to bring the bowel to the ureter rather than stretching the ureter to the bowel. This can be done in a running or an interrupted anastomosis with 4-0-5-0 absorbable suture. You want to minimize touching or grasping the ureter. You can use a stay suture on the ureter to help you move and manipulate the ureter rather than grabbing it with your pickups. And test the anastomosis before leaving the OR. Oversew any little leaks, and then you can retroperitonealize your anastomosis. Obviously, stent your anastomosis, place a drain, and with conduits, you may or may not leave a red rubber stomal catheter as well. So these are just some examples of types of ureteroenteric anastomoses. Most common is the Bricker anastomosis, which is a refluxing type anastomosis. We tend to not perform anti-refluxing type anastomoses in the modern day, but many have been described. And then the other common anastomosis type is a Wallace, where you sew the two ureters together and put them to the butt end of the conduit, which tends to have the lowest rate of stricture. Things we worry about in terms of complications: upper tract deterioration. This can be a result of lack of ureteral motility, UTI, or stones, and this can occur long term. Leak rates are around 3 to 5%, and these usually occur early after urinary diversions. Acute pyelonephritis can occur early as well as late into survivorship, and it can be associated with stricture development. Long-term renal dysfunction can occur around 18% with conduits and 15% with colon conduits with anti-reflux in those patients who had normal kidneys preoperatively. That then deteriorated, rather than patients who had CKD at the time of urinary diversion. So looking at stricture rates after ureteroenteric anastomoses, these can be caused by tension or ischemia at your anastomosis, a leak, urinary tract infection, or pyelo, patients who have had radiation or trauma. These can occur late, so it's important to monitor patients well into survivorship. These can occur, 8 to 10 years after urinary diversion. These also can be non-anastomotic, which is most common on the left side because you had to mobilize the left to bring it across the sigmoid mesentery to do your anastomosis. These strictures are more common with non-refluxing anastomoses compared to refluxing. The average rate for Brickers are around 6%. With the Leduc, Pagano, and Ledbetter-Clark, these are all non-refluxing anastomoses, and highest risk with the Leduc. The Wallace, as I said, has the lowest risk. These can be running, having a running or interrupted anastomosis, unclear whether or not relates to future stricture development. Hauptmann looked at his series of ileal neobladders and found that stricture rates were higher with preoperative hydronephrosis, with 20% risk of stricture, whereas those without pre-op hydronephrosis, the stricture rate was 7.5%. There's some evidence that robotic surgery may be associated with increased risk of ureteral stricture development. This was a SEER study published recently showing that, again, pre-op hydro was a risk factor as well as doing a robotic diversion. But this didn't differentiate extracorporeal versus intracorporeal. Also looking, another study also similarly found that robotic cystectomies with intracorporeal urinary diversions had higher rates of ureteral stricture development. Often now we can use ICG, which may help us better assess the vascularity and the health of the ureter. And using ICG was associated with resecting more ureter than you would have otherwise. And this was associated with no ureteral stricture developments when ICG was used in the study versus 6.6% per ureter or 10.6% per patient in patients where ICG was not used. In terms of management, it's kind of beyond the scope of this lecture, but endoscopic management, tends to not provide long-term durable results. You can try a balloon or a laser or sharply incise, but typically the highest success rates are with open revision. There's worse success if you're shorter time from surgery or if you have a longer stricture. So just to go over the different urinary diversion types. So incontinent, in terms of incontinent urinary diversions, the simplest being a cutaneous ureterostomy. This avoids the need for bowel anastomosis in the bowel work. And University of South Florida published their experience with 310 cutaneous ureterostomies. They managed these differently during their series. Some early on, they left stents only for 3 months or really perioperatively and found higher stricture rates. Whereas when they left the stents in for longer, they found that the stricture rates were less and less likely needed revisions or chronic stenting. Ileal conduit is the most common incontinent urinary diversion. You may want to consider an alternate segment in patients with pelvic radiation, those who have inflammatory bowel disease involving the small bowel, or those who already have had prior bowel resections and short bowel. Preoperatively, important to mark the stoma site, get with your ostomy nurse. You want to choose a site in the right lower quadrant, over the body of the rectus. Typically, we use a 10 to 15 centimeter segment of ileum, about 15 centimeters or so from the ileocecal valve. You want this isoperistaltic, meaning the distal side goes to the stoma and the proximal side of the bowel becomes the butt end. As I said, typically doing a refluxing, spatulated end-to-side anastomosis or a Wallace are the most common. And you want to mature the stoma through the right lower quadrant, through the body of the rectus with a 2-finger hiatus. You want a perpendicular track between the peritoneum and the skin, and you want to avoid a diagonal course, ensuring that the mesentery remains medial and is not twisted, and doing a rosebud type stoma. So talking about stomas, you want a protruding rosebud or brook type stoma. This enables placement of an ostomy appliance and prevents the skin from getting macerated and chronically inflamed. Like I said, you want to bring it through the body of the rectus muscle. You want to avoid skin creases, avoid the belt line. You can or cannot, fascial fix the conduit with the cruciate incision of the anterior fascia. Doesn't seem to make a difference in terms of stoma rates. A Turnbull stoma, may be used in obese patients with short, thick mesenteries. There's high rates of peristomal hernia, but less risk of stenosis. Requires a larger segment of skin to be removed, and you bring up the distal blind end cephalad, and this is where you can incise the mesentery a couple centimeters away from the bowel. You can see my pointer here. You want to remove some of this mesentery so that the mesentery continues to be straight, and this piece of bowel will actually survive. You want to put a red rubber underneath, which is here, or some sort of device to keep the loop up, and only keep that in for 7 days. And then open the bowel transversely. The blind end can be anastomosed flush to the skin, whereas the actual end of the conduit needs to be rosebud as well to enable bagging. Colon conduits, you want to avoid these in with patients with ulcerative colitis, chronic diarrhea. If they have small bowel only Crohn's disease, you can use the transverse colon. The transverse colon can be used, is a nice thing to have available in patients who've had prior pelvic radiation or have really short ureters. You can actually anastomose the transverse colon right to the renal pelvis. And can do a side-to-side stapled anastomosis or end-to-end, similar to the ileal conduit. And it can be placed in any orientation. It can be isoperistaltic or antiperistaltic. Most commonly is placed in the right upper quadrant. The sigmoid colon can also be used. This may be a good choice in patients undergoing pelvic exoneration, and can be placed on the right or the left, and avoids the need for a bowel anastomosis. So it's a nice option to have. Or you can also use an ileocecal conduit. The ileal part of that can be used to anastomose the ureters and creates an anti-reflux mechanism for the ureteral anastomosis. So I'm going to skip the quiz just in the interest of time. The complications of ileal conduit, bowel leak 1 to 2%, wound infection, dehiscence, ileus, GI bleeds, urine leak around 2%, renal failure. As you can see, the complication rates overall around 60%. So these are not benign surgeries. Some of the complications long-term tend to be mostly related to the stoma. And these are long-term issues for patients. The stoma can retract if there's tension on the conduit or stomal separation, especially in obese patients. You can get conduit necrosis. Early on, if you're worried about the health of the stoma, you can use a test tube and put it in the stoma, and it allows you to see proximal to the skin level to make sure that the entire conduit isn't ischemic. Peristomal hernias are probably more common than we appreciate. Many of these are asymptomatic, but about a third seek repair due to issues with pouching or bowel obstruction. It is more common, like I said, with a loop. Memorial Sloan Kettering is actually doing a trial using prophylactic mesh to prevent these. Stomal stenosis can be a result of chronic infection and vascular insufficiency or scarring at the skin level. We see this in a 20 to 24% in ileal conduit and 10 to 20% in colon conduits, but it's less common with loop ostomies. There's been less rates of this reported as a result of better fitting ostomy appliances and better attention to stomal care. Conduit prolapse and peristomal skin irritation and ulceration can also be problematic for patients. So these are just a couple of pictures showing stoma stenosis of the conduit. In this picture up here is a patient that I saw during fellowship with a necrotic conduit. So moving on to continent diversions, over time there's been decreasing use of continent diversions, which you can see here. However, this is center dependent. Some centers, may say that they do about 70% of their diversions are continent diversions. But overall, probably less commonly utilized across the board than ileal conduits, which tend to be the most common. So again, I'll skip over the question just to get through more of this. So in terms of selecting patients for continent urinary diversions, oncologic factors to consider. If there's a positive urethral margin at the prostate in men or the bladder, neck in female, you don't want to do a orthotopic neobladder. However, there's some evidence that orthotopic neobladders may be associated with lower risk of urethral recurrence. It's important that they have relatively normal renal function. If they have a GFR less than 35 to 40, you probably don't want to use a continent diversion. Patients need to have normal liver function, no inflammatory bowel disease. Patients who've had prior bowel resections, you want to, may need to make an intraoperative assessment whether or not you're able to use a sufficient amount of small bowel or colon to use for diversion. You also want to avoid devascularizing bowel, and you may need to take down an old anastomosis. If it's close by your segment that you're going to use. If you're using the colon in your diversion, they need a recent normal colonoscopy. Also consider mental and physical factors. Are they active? Do they have good dexterity? And are they willing to take care of the continent diversion? Patients who are concerned about cosmesis or having a bag, you may consider this as well. Patients with urethral stricture disease or poor external sphincter function, you may want to avoid using a continent diversion. As patients with radiation, you may selectively do an orthotopic diversion in these patients. But continent catheterizable channel is certainly reasonable in patients who've had radiation, assuming that they meet the other criteria. So in terms of orthotopic diversions, they need to be have excellent compliance, and they need to maintain a low pressure, store adequate volumes, and most of these patients void by Valsalva. In females, you want to preserve the urethra and keep the endopelvics intact. Nerve sparing may be beneficial in terms of reducing hypercontinence, and also may consider sacrocolpopexy, which may aid as well in supporting the neobladder and preventing kinking or hypercontinence. as well as putting omentum between the neobladder and the vaginal closure to prevent a fistula. So different types of orthotopic diversions. I'll just go through this quick and let you guys read some of this on your own in the interest of time. But the Hauptmann neobladder uses 60 centimeters of ileum in a W configuration here, as you can see. The Studer is the other most common orthotopic diversion. Similar principle, but smaller segment of bowel utilized. And then in terms of troubleshooting with urinary diversion, so it's important to make sure that the bowel is going to reach the urethra. If you're doing a Studer, you can bring the point 12 centimeters from the distal isolated segment. If you can bring that to the base of the penis, you're pretty well assured that you'll be able to get it down into the pelvis. With a Hauptmann, you want to mark the most dependent portion of the ileum and make sure that segment reaches the symphysis. Intraoperatively, if you're having trouble, you want to loosen the retractor, straighten the table, take them out of flex, remove a cushion if there is one. You may need to use a sponge stick to push up the perineum. You can mobilize the cecum and the root of the mesentery to help you get extra length. You may use a discard segment, which has been described, the proximal portion, to improve the mobilization, as well as superficial peritoneal incisions, which you can see here, which may enable you to stretch the bowel down. In terms of management, I'll skip this. And in terms of urinary diversion outcomes, majority of patients do achieve daytime continence, may take 12 to 18 months. Nocturnal incontinence tends to be more of a problem, as higher rates of the Studer neobladder relative to the Hauptmann neobladder. In terms of complications, hernia, incontinence, hypercontinence can occur between 4 and 25%, is more common in females. Ureteral strictures, similarly to incontinent diversions. Anastomotic strictures are rare. Fistulas, UTIs, pouch stones, and then as well as the metabolic complications that we talked about. So continent catheterizable channels, there's several different versions. Most commonly is an Indiana pouch or some modification of the Indiana pouch, which is the pen pouch, or the Miami and Florida pouches. The ileal continent catheterizable channel, the Coke pouch, is not as commonly used. So this is the initial description of the Indiana pouch. This is based on Gilchrist's original description of using the right colon for a diversion, but he didn't detubularize the segment. So there were issues with high pressure and incontinence. So this relies on using the right colon, typically up to the hepatic flexure, about 20 to 5 to 30 centimeters of the right colon and 10 centimeters of the ileum. And then opening it up on the antimesenteric side and clamshelling it close, and then using a tapered ileal limb with a reinforced ileocecal valve as the continence mechanism. And here's just showing the incision. You can do it, then you do an ileocolic anastomosis, similar to your ileal anastomosis. Staple reduce this ileal limb as a catheterizable channel, and then can put some Limburg sutures at the ileocecal valve to reinforce. You want to test the continence mechanism, before bringing up this limb to make sure that it is going to be continent, and also test catheterization and test it multiple times before pulling it up through the abdominal wall, as well as after pulling it up, to make sure that the catheter passes easily. Because if you can't catheterize it intraoperatively, the patient's not going to be able to catheterize it themselves. And then in terms of outcomes, so late complications, you can get stomal stenosis, peristomal hernias as well in the catheterizable channels, pouch stones, gallstones, metabolic acidosis and renal dysfunction, as well as incontinence of your intended to be a continent diversion. And this can be failure of the continence mechanism or related to contractions of the pouch. So in terms of long-term complications of urinary diversion in children, they can have impaired growth and development, recurrent infections. They may develop stones, not only stones within the pouch as a result of, if it's a continent diversion with mucus, retained mucus, but also because of chronic acidosis, hypocitraturia, and so they may, as well as bacterial colonization, that may result in stones, both kidney stones as well as in the pouch. Osteomalacia may occur as a result of chronic acidosis, where the bone releases calcium. So you want to treat the acidosis as well as supplement calcium and vitamin D in these patients. As well as, they may have vitamin D deficiency as well. Secondary malignancies typically occur late. This was most commonly seen with ureteral SIGs, which is why they've largely been abandoned. It was interestingly found that patients who had the urothelium from the ureter that was left in contact at undiversion, that those patients were at higher risk even if they were defunctionalized. So it's important to remove the actual anastomosis and the piece of bowel that it's connected with to prevent malignant transformation. Typically, the secondary malignancies within the pouch are rare, 0.2%. Most commonly, as I said, in the ureteral SIGs. After 5 years or so, you may consider endoscopic evaluations, especially with right colon pouches, and looking in to make sure. Quality of life varies significantly. These are several different instruments that have been used to assess quality of life in different urinary diversions. And typically, this is an individualized decision, and so the quality of life really depends on a variety of factors, that's specific to that specific patient. And it's hard to compare, one diversion, a patient who gets one diversion, since they don't have multiple diversions to experience. In terms of follow-up, these patients will be followed long-term. Oftentimes, they'll get imaging if this is a bladder cancer patient. You want to surveil their upper tracts with CT or renal ultrasounds, pouchogram or lupograms if you're assessing for reflux or stricture. If they have new hematuria with an orthotopic neobladder, important to do a cystoscopy to make sure there's no urethral recurrence. And these patients need lifelong follow-up. So the take-home, know your anatomy and the surgical techniques. You want informed discussions with your patients and individualized surgical plans with a multitude of considerations to make. It's important to know the metabolic consequences, which are highly testable, recognize the complications and the management. And even if you don't perform these surgeries, you're going to see these patients on call or in follow-up, and they'll certainly be on your boards. So with that, thank you very much. Sorry for the whirlwind tour of urinary diversions. I'm happy to answer any questions that you guys have here. Okay, I'm looking at the Q&A. So someone asked the difference between intracorporeal and extracorporeal urinary diversion. So what this means is that you don't undock the robot to create your urinary diversion. So you continue to harvest the bowel, do your reanastomosis of the intestines, whatever diversion you're using, do your ureteral anastomoses, and then if it's a neobladder, do your vesical urethral anastomosis, all with the robot there. An extracorporeal diversion is where, after doing the cystectomy, if this is a bladder cancer patient, you would make a little mini laparotomy incision and then do all your intestinal work and your anastomosis, in the typical fashion, just through a smaller incision is the difference between the two. Does performance, so nerve sparing, yeah, it has been shown nerve sparing. The question is whether or not nerve sparing results in improved nocturnal incontinence in patients. I think yes, that it has, and improved also hypercontinence, less rates of hypercontinence when you preserve the nerves. I think some of the nocturnal incontinence is related to how quickly and how easily the bowel is able to accommodate volume. Where, with the Houtman neobladder, you tend to have a higher volume at the outset compared to a Studer, obviously you have your reflex arc is not the same as with your native bladder and preventing leakage at night. So your sphincter doesn't necessarily communicate the same way it does with your native bladder as it does with an orthotopic neobladder. Okay, so this is a medical student asking, so these procedures, I would say the question is how much are these procedures done in residency versus fellowship? I would say it's variable depending on where you train. I mean, you should have, I mean, every residency is going to have some exposure to urinary diversions and intestinal work. I mean, it's a requirement to do, so many I think 5 cystectomies. That you have to participate in during residency. Depending on your center, you may have more or less exposure to the continent diversions, the Indiana pouches, and orthotopic diversions. In some places that may push to may do them more frequently. Where I trained in Houston at MD Anderson, I mean, I would say a majority of our cases were conduits. Maybe 80% conduits, 20% continent diversions, whereas a center like USC does 70% continent type diversions. In terms of pouch stones, I would say depends on whether or not this is an orthotopic neobladder or a Indiana pouch. The question is, how do you manage the pouch stones, and also the size of the stones. Certainly, if you're doing an Indiana pouch, and you have big stones, you don't want to use the catheterizable limb, the efferent limb, to do lithotripsy through, because you may disrupt the continence mechanism. So typically you'll do a percutaneous access through a separate site with your Indiana pouch, and do like you're doing a PCNL, but doing it through the abdominal wall directly into the pouch to manage the stones. There's another question: how does hydronephrosis after ileal conduit in the setting of UTI or AKI necessitate stent versus PCN placement, even if hydro is likely secondary to reflux? So I'd say to answer that, it's largely dependent on the clinical scenario and kind of your imaging findings at baseline, usually on a scan. I mean, if you can see that there is obstruction, if there's a stone, sometimes they'll have stones. If they have delayed imaging, you may see a stricture. So in that case, you may point you toward doing some sort of drainage of the upper tracts versus sitting on it, treating the infection with antibiotics. So I'd say it largely depends on the scenario, what the imaging looks like. And certainly someone who's acutely infected and is sick, you're not going to want to do a leukogram on that patient because it may exacerbate and worsen their sepsis. So if there's any question, they're little down and they're super sick, there's little downside placing a nephrostomy tube if you're uncertain as to if they're obstructed or not. In terms of, there's another question: how long do I keep ureteral stents after a conduit versus a neobladder? And how do you manage anastomotic leaks? So for ileal conduit, typically we'll leave the stents in for 5 days. I would say at baseline. All these patients also have JP drains, so some of that's dependent also on the clinical scenario. If someone with irradiated patients, you may consider keeping the stents in a little bit longer, especially if you're worried about it intraoperatively and worried about the health of the ureter. But I would say average is about 5 days. Check a JP creatinine before you remove the stents in those patients. With neobladders, leave them in somewhere between 7 and 10 days. Similarly, make sure there's not a urine leak before you remove the stents. With the neobladder, I didn't get to it just in the interest of time, but some people will actually tie the stents to the catheter in the neobladder. And so when the catheter comes out, the stents come out. So they may wait 2 to 3 weeks and do a cystogram and then prove that the neobladder is healed. And then at that time, the catheter comes out, as do the stents. Other people will bring the stents out through a separate incision and through a separate site on the abdomen to remove them independent of the catheter. In terms of managing leaks, assuming that the stents are in, you continue to keep your drains, continue to keep the stents in place, and maximally drain everything. And sit on them is largely the answer. If there's a big leak, an intraperitoneal leak and there's a big urinoma, in those cases you may consider placing a nephrostomy tube, another drain in the abdomen. Very rarely do you have to go back and re-explore someone for an anastomotic leak. Typically, these will heal, with further drainage, continued stent, and maximal diversion. And then, so I'm about out of time, but quickly, thoughts on concurrent bladder neck closure. I would say it depends on the case. If you're doing an augment with a bladder neck closure, I mean, that's commonly done in the pediatric world in the, for, neurogenic bladder kind of thing, or extrophy epispadias. But in the adult world, bladder neck closures are a little more tenuous. Would not do that in a radiated patient. But it can be done. It's easier to do in females in general than it is in males. You may have to do a prostatectomy in males. It also depends on where the ureters are in relation to the bladder neck. If they're super close, you may need to stent the ureters or do a reimplant, so it may be more complicated. With that, thank you guys very much. I'm happy to answer any other questions. Sorry, I forgot to put my email up. My email is cbenson2@tulane.edu. If you guys have any other questions, happy to answer any of them. Again, thank you guys so much for letting me talk, and I think we're out of time.